So I was asked to talk about the natural history. I'm going to do that briefly. I think most of you know the natural history, but I'll deviate a little bit. I'll take speaker's prerogative here. So I have no relevant financial interest in this presentation. So it's been our premise that early diagnosis and rapid assignment to algorithmic care in the acute setting can limit the development and progression of multi-system sequelae, including those of the eyes, and limit lifelong morbidity. And in the absence of that, the natural history of patients with SJS-10 can range from stable and good vision to episodic worsening to a slow, gradual progression to blindness. And I'll talk a little bit about the systemic complications, but it's well documented that the ocular complications are the most common and debilitating. Thank you. So I wanted to address this very briefly, incidence rates. So whenever I talk in when there are Europeans present, they argue with me because the incidence in Europe appears to be around 1 to 2 per million per year, truly a very rare disorder. But we questioned whether this was accurate, at least in the US, and asked that question. And to do that, we used the National Emergency Department sample, NEDS, which is a huge all-payer database in the US containing between 25 and 30 million records. And what we found going through diagnosis codes, and this was laborious, but I think accurate, we found an incident rate of about 10-fold higher in the US, of about 12 cases per million persons per year. Now, no matter how you identify incidence rates, there's always a bias, and there were cases in which we were trying to determine whether that coding was for acute SJS or a patient that had had it previously. But you know, when a patient comes in and the primary code is broken leg and the second code is SJS, that's probably SJS. They got antibiotics during the surgery for their broken leg and then got Stevens-Johnson syndrome. So using that incident rate and then using a conservative estimate of about 1/3 of patients that have moderate to severe reduction in vision after the disease. And in the US, I think Darren would agree, the care of patients in US hospitals is still quite spotty. So there are many burn centers now that have ophthalmologists who are dedicated, but I would suggest that the majority of patients in the US do not get specific ophthalmic care. Some of them only get glass rod and artificial tears. So when you look at that and you look at and apply that to worldwide population, you start to see quite a few cases. And then we could estimate about 30,000 cases a year of patients coming to us with moderate to severe visual loss out of the subacute phase. And this is a really huge burden, and we've estimated that there clearly aren't enough of those ophthalmologists interested in this disorder to take care of all these patients. So I'm going to show you just a few random images so I can satisfy my mission of showing you the natural history. But all of us know what toxic epidermal necrolysis looks like. This is a particularly severe case. And we all know what the mucositis looks like in the mouth, and these are characteristic lesions. This is a patient of mine with a pseudomembrane forming, and what's really amazing and characteristic is the severe meibomitis that you can see, and this is what I see in almost every patient. I think these are your pictures, Darren, but this is an example of just a couple of hours later here, and this exam can change very quickly. So if you see the patient at 8 in the morning, at 4 in the afternoon, it can look quite a bit worse. But the chronic complications are maybe a little bit more stereotypical, and we've all seen patients with pannus. This patient had a pannus that gradually took over their vision. We know about entropy and trichiasis, the eyelid margin changes, and the lid margin keratinization that we're hearing so much about. And this is really, I probably see as much of this as I do of any other manifestation because I get referred patients with end-stage ankyloblepharon for surgical mediation. And this is, I think, a case of Charles Bouchard's that I just thought was a fantastic example. What about systemic manifestations? Well, this, I think, is a really important feature that all of you as ophthalmologists, I believe, should be thinking about and talking to your patients about. Why would you talk to your patient about respiratory symptoms? Because no one else will if you don't. No physician will say, gee, you're having trouble breathing. Did you know that's because you had SJS? These patients, many of them develop acute respiratory illness during their acute illness and then following that will develop chronic obstructive pulmonary disease. And it's amazing when you say, are you having any problems with your breathing? And they say, oh yes, since I got out of the hospital, I'm having so much trouble. And for women, gynecological complications are extremely common, and they have been essentially ignored in the literature. There's just a few papers. We finally identified a gynecologist at Mass General Hospital who'll see our patients, and I ask every female new patient to me about gynecological complications so that I can make a referral. So I'm essentially doing what their primary care doctor should be doing, but who doesn't really understand the chronic complications of the disease. And I think you can do a big service to your patients by talking to them about systemic complications. We also are trying to push the system forward in the burn ICUs so that patients, not only are specialists called to the ICUs to see patients in their area of specialty, but at discharge, patients are talked to about these chronic complications and given referrals when they have breathing problems, for example, so that they can get specific care. So hopefully push the care forward. The acute ocular complications, this is review, I think, for almost everybody here. Ulcerations, just anywhere along the eye surface. Inflammatory membranes, severe myomitis, and we know that blindness can occur in the acute phase. Untreated patients who have severe disease can leave the burn unit with LP vision. Okay? How does that occur? They can have ankyloblepharon when they leave if their adhesions haven't been treated, and they can even have a corneal perforation in the unit while they're there acutely. And obviously, that's a really bad patient to do a therapeutic graft in when they're in acute SJS. In the chronic phase, tear deficiency, eyelid margin keratinization, limbal stem cell dysfunction, which can lead to pannus, persistent epithelial defects, scars, and ulcers, symblepharon and ankyloblepharon. And some SJS patients experience chronic or episodic ocular surface inflammation. And I think we heard about that, but we didn't really explicitly discuss this yesterday. And this is from De Rojas, Dart, and Saw's paper. I don't know about all the arrows here, but I think if you think about it and just recognize that patients after SJS can never quiet. In other words, they have inflammation that continues without relapse. They can get quiet and then have episodic bouts of inflammation, or they can have quiescence. And we see all those patterns, and I'm not sure that any one patient has any one pattern throughout their life, except the patients that have chronic inflammation, they can go on and just have chronic, and sometimes patients could be quiescent, but this episodic inflammation is interesting. So blindness can occur at any time following the acute episode, acutely or years later. This is a patient of mine who's 57 in this photograph, had toxic epidermal necrolysis at age 10. She had poor vision in the left eye from that time, but good vision. She was a physical therapist working next door until age 50, and this is what her right eye looked like, and this quickly became completely opacified while she was seeing me. And we couldn't get her to the operating room fast enough to do anything about it. It was literally within weeks of my first visit with her that the pannus crossed her visual axis. All right, so there are windows of opportunity. These exist in acute disease that, if acted upon, can have a major impact, and that's why natural history is so important to appreciate. And I think that an ophthalmologist should see every patient, whether they have a red eye or not. Darren has a wonderful picture of a patient with a large corneal epithelial defect who has no inflammation apparent. And if you look at that eye with a pen light, you would never know that the corneal epithelium was absent. How to do that? You have to make yourself known to the doctors that see these patients and let them know that you're available to see them. And patients can worsen rapidly, so those with a normal exam should be rechecked frequently. I like to try to follow Darren's 6-day rule for getting the amniotic membrane graft in when the patient has an indication. So I like Sotozono's classification because it's so simple, it's so easy to use, and any patient with eyelid surface, eyelid margin defects, or pseudomembrane formation gets amnion unless they refuse it. I don't have to think real hard. The fellows don't have to think very hard. And at 4 in the morning, no one wants to think very hard. So I try to keep it as simple as possible because amnion placement has very low morbidity, except for the brief interruption in good vision. If they are seeing well and are conscious, I think there's a low downside. So in chronic SJS, there's also critical windows of opportunity. And I think we talked about all this yesterday, but it needs to be very explicit. If you see something, do something. Patients can progress from 20/20 to LP vision over several months. These patients need follow-up. So I follow every patient who comes out of the ICU or hospital with SJS that is identified to me. And I never let them out of my practice. Because first of all, I want to learn what's going to happen to the patient that seems to be doing really well in 10 years. I don't think we know that answer because we have no real natural history studies. No one's done a real long-term study of SJS from a registry perspective. We're trying to do that. And that's important. And eyelid margin keratinization, which can occur late, certainly depletes the limbal stem cell reserve, and the patient may look good and have a normal corneal epithelium with a little keratinization when you see them. But if you don't follow them, that patient can turn into a visual disaster. So we look for eyelid margin keratinization and corneal epithelial fluorescein staining at every single visit. That's a key element for us. And we act before those windows of opportunity close. So you have to recognize them and act. Wishful thinking doesn't help these patients. Hoping that lid margin keratinization won't hurt their cornea and not following them does not protect them in any way. You then become responsible for that bad outcome, in my personal opinion. Okay, so if you see something, do something. In the acute disease, if you have defects or membranes, place amnion, give steroids, treat them with prophylactic antibiotics. In the chronic phase, we see deficiency of tears, trichiasis, persistent defects, keratinization. Punctal occlusion is a key method. I learned that at Shankar Netralia in seeing the patients before and after just punctal occlusion. It can have a major impact on comfort. Scleral contact lenses, as we've learned, are very important in mucous membrane grafts. And originally I thought these were sort of mutually exclusive, but I've come to see that they can be complementary in the same patient. This is a paper from a paper we published on PROSE lens, looking at longer-term longitudinal outcomes after placement of PROSE in SJS patients, and the visual acuity was improved right after optimizing the lens, so very early, and it was maintained over time. Not only was visual function improved, but so was self-reported general health. We've heard a lot about mucous membrane grafts. These are Geeth's photographs, and this has been nicely published and shown in this paper in Cornea. And for those patients who are end stage, we also learned about some really innovative methods yesterday for using keratoprosthesis. This is a patient of mine who, unfortunately, at age 14, someone did keratolimbal allografts and put her on systemic immune suppression, which is not supposed to be done. And she perforated the left eye and has done now almost 10 years out with type 2 keratoprosthesis and excellent vision. So in conclusion, acute SJS-10 can lead to moderate to severe visual loss in 1/3 or more of cases. Visual loss can occur in the chronic phase. It can be continuous inflammation or episodic, and I think recognizing that, once you accept that, it's not puzzling, it's not easy to manage, but it shouldn't surprise you, and you should be prepared to address it. Patients with normal vision at the end of the hospitalization may lose vision even years later, and all SJS-10 patients should have regular periodic eye exams. And what I do is I start seeing them relatively frequently, and as they show me that they're not progressing, I lengthen those. But I see there's no patient, even with normal eyes, that I don't see at least once a year. And I just tell them, you're helping me, and you're helping the next patient with this disease, because as I'm learning about this rare disease, I'm better able to serve those patients that come to see me in the future. For patients that leave the hospital with good vision, keratinization of the eyelid is the most important thing that you can identify to save them from long-term visual loss. And with that, I'll stop, and thank you very much.
Thank you, Dr. Chodal. Just hang on for a moment. So we have a list of questions that the attendees have sent us before this session. And you covered pretty much all of them except for one that I can make out. Could you comment on some atypical cases that don't have cutaneous manifestations? Yeah. And are there any confirmatory tests to diagnose SJS in the acute as well as chronic phase?
I mean, technically, SJS is, less than 10% body surface area. So there are reports in the literature of SJS without skin lesions. I'm going to talk about this in science talk that I'm giving for him later today about the differential diagnosis of cicatrizing diseases. I'm not really sure what that is, and since SJS, in the absence of a skin biopsy showing epidermal necrosis and sparing of the dermal layer, I don't know how I can make that diagnosis. One of the things we really lack that I would encourage those of you with access to work on is a biomarker for the disease that's better and more rapid than skin biopsy. We need a way to make the diagnosis rapidly. And it looks like Sign's going to comment on that in a second. But there is the entity of mycoplasma mucositis, which can cause the mucosal findings that are very typical for SJS, but typically has very minimal skin findings. And there's been a question, you know, if mycoplasma can cause SJS and mycoplasma can cause mucositis that's not SJS, then how do we resolve that apparent paradox? But in the absence of skin lesions, I become even more suspicious of mycoplasma as a cause. And I think that patients should be tested for mycoplasma as a routine, personally, by antibody testing and perhaps by culture. So, Sign, did you want to comment?
No, I just wanted to make a quick comment that on the same lines that you were saying earlier, that if I have a patient who's not had, and I'll speak briefly about it in my talk, but if I see a patient that has not had any skin manifestations, no lesions, but presents with a chronic sequelae which looks like SJS, and like you said that this could be, you know, the different pathways converge, so all the cicatrizing conjunctivitis after a point in time look very similar. But I would not label them SJS because labeling a patient with SJS makes you think a certain way. And that can lead you to not give the patient the treatment that he or she requires or the workup that he or she requires. And that is very important because if you have labeled the patient SJS, that label sticks and everybody, and you yourself included, treat the patient thinking that this is SJS, this is what is going to happen, these are the things that we can do, and you would never think of the workup that is required, the underlying autoimmune diseases that need to be looked for. And if you miss that, then you keep struggling, and then you wonder, why is this SJS behaving abnormally? But maybe it's not SJS. And that labeling, I think we should be a little bit conservative in labeling patients with SJS when skin manifestations are completely not there or very minimal.
I agree with that. I think that it anchors our thinking, is what you're trying to say, into a certain category once we've labeled the patient, and that's not productive for the patient. It also prevents us from learning something new. So if we've forced our thinking into one direction of SJS, and everyone with these eye changes have SJS, we can't learn about this other possible entity, right? So it locks us out mentally from being open to another entity. I totally agree. And so, idiopathic is I like to say idiopathic means the doctor is an idiot. That's how you get to idiopathic. But, we need to be smarter for these patients. But I agree. Other questions?
Yes. Would your treatment will be differing for these two groups where you have?
So I think Jim will discuss that in his talk on differential diagnosis and management of cicatrizing conjunctivitis. So we'll have that later in the day.
All right. Any other questions, comments for Dr. Chodosh?
Just a preview. The mycoplasma mucositis typically is associated with much less severe ocular complications. Patients can have dry eye, they can have changes, but it's nothing as severe as what you see in what we call Stevens-Johnson syndrome. Okay?
Right.
Questions?
Yes, questions.
So this is one unusual case actually. We had a acute SJS in a 7-year-old child. 7-year-old child who was an epileptic and admitted in a children's hospital. And we were asked to see the child. We went and we have seen the kid. We have done the amniotomy and everything. After a week, the child was asked to come once it was stabilized to the hospital. But that is when the parents noted the child was groping. He was not able to see anything. We had actually checked his pupillary reactions, his retina, everything was fine, but the child had ended up having no vision. And the VEPs were done and it showed extinguished waves. So it was very unusual, and I just wanted to know if anybody has noticed
So
this. And
you're saying the visual evoked potentials were extinguished in the child?
Yes, yes, yes.
And, I would posit that very likely has nothing to do with Stevens-Johnson syndrome as a disorder, but might have something to do with something the child ingested or was given that was toxic. Any other thoughts from anyone? So I like to say that SJS causes glaucoma, for example. It doesn't, but the treatments that patients get, steroids, can cause glaucoma if it's not monitored. But I don't know how the visual evoked potentials would be affected by SJS. There's evidence that in alkali burns that the retina undergoes changes. We don't know about SJS. I think it's an interesting thought. Corneal inflammation, corneal transplantation can cause changes in the retina. Microbial keratitis causes changes in the retina, but none severe enough, except in the most severe alkali burns, to ablate a visual evoked potential. So I'm a little skeptical that there was a direct relationship. Jayesh, do you have any thoughts?
Absolutely not.
Because we've seen the child just after a week and still the child is not recovered at all.
And the eyes look normal?
Yeah, the retina has been checked, everything has been checked. Fortunately, the surface has healed, but the child is not having vision.
And we're pretty sure this was not the case before.
Yeah, that's what the parents told. That's all.
Right.
Strange. Yeah, that's what I was saying. Something the child ingested. The comment was a toxic optic neuropathy because of the drug, or perhaps a drug that they used to treat the SJS. Yeah, we don't know. Okay, I'll get off. Thank you so much.
All right. Thank you, Dr. Chodosh.
So, good morning, everyone. Firstly, apologies that I won't be able to hang around for the rest of the meeting, although I would very much love to, because there are some commitments back at the institute that I have to fulfill. I also want to congratulate Vikas on putting all this together, and I think it's still early days because it's just begun, but I think this is the biggest and the grandest and looks like the best workshop we've had so far. So thank you so much for taking this forward and putting all the hard work. I know how much goes into it, but you also gave me 2-3 months of free time this year, so I was able to use that, write some papers. So I'm going to make some important points because we're just starting off, I think, a couple of days of discussions on SJS, and through the course of the meeting, you'll go over and over the surgical techniques, etc. So I'm not going to touch on those things. I'm going to basically speak about what our experience has been, and here to understand the natural history, how the natural history changes when you do interventions. It's very important because you can take this information and then pass it on to the patient. So when you're advising them treatment and they ask you, okay, how is this going to change things for me? Then this data can help you make them understand what would happen if you did not make this definite intervention. So I have a lot of data to present, so I'll go very slowly so that you can absorb the information that I'm giving you. Sometimes the information will be a little bit overwhelming. Please feel free to stop me in between and ask questions if you want to. Jim talked about this, that SJS, you can distinctly divide it into 2 phases: the acute phase, which presents with necrolysis, and the chronic phase, which presents with cicatrization and dry eye. I'm not going to go into what are the exact changes that occur, etc., because in the next session, Dan will lead the discussion on how acute SJS has to be managed, and I think he's the best person, along with Jim, to teach you that. I don't see acute SJS at all because we are a standalone eye hospital. We get referred cases that have already had SJS. The acute phase is over. Now the patient can walk around and can come to the ophthalmologist. Okay? This is also important. If you have a patient that has come to your clinic and you're making a diagnosis of acute SJS, you're making a wrong diagnosis. It can't happen. Acute SJS, you go and see the patient. The patient doesn't come and see you. If the patient is coming and seeing you and has acute manifestation, the patient is something else. And this is very important. When you're seeing chronic sequelae of cicatrizing conjunctivitis, how do you know it's SJS? And I would like to emphasize this point again and again and again. Do not label patients SJS until you're absolutely sure that they are, because the treatment of cicatrizing conjunctivitis that is not SJS is very, very different than SJS. But how do you know? So I know that a lot of you who are sitting in this room, and I think probably Dan and Jim are the only exceptions here, or a few of you who see cases of acute SJS. Most of us are seeing the chronic sequelae. And then you're trying to make a retrospective diagnosis, or you're taking the label that the patient is carrying as the truth. You're saying, okay, this is a known case of SJS, so refer as a case of SJS, and you assume that it is true. So I'll give you a helping hand. Two things that you need to take into account. One is the past history of the patient. So typically, patients with Stevens-Johnson syndrome will have a history of sudden onset of symptoms preceded by fever or drug intake, with skin eruptions which progress to boils or bullae, with subsequent rupturing of the boils and bullae and sloughing off of the skin, which is the necrolysis. They may also have history of loss of nails on the fingers and also on the toes. And they will have the red eye and the oral ulcers, which is mucositis, associated with skin lesions, not in isolation. And usually the patients are very sick and they need to be admitted in a hospital. So they will have a history of hospital admission, typically of a burn ward or an ICU admission for 2 weeks or longer. Okay? So all of these points, if they are present in the history of the patient, they get 1 point. Okay? If they have red eye and oral ulcers without skin lesions, that's a -1. If they have a slowly progressive disease without an acute episode, that's a -1. If there is no sloughing off of skin or rupturing of bullae, the patient says that I had vesicles or I had chickenpox-like lesions, but they didn't progress and my skin didn't come off, that's a -1. If the patient can't remember if they had skin lesions or not, that's a -1. And if they have recurrent mouth ulceration, so patient says, oh, I had this drug reaction. What's a drug reaction? Somebody told them you had a drug reaction. How does the patient know that patient had a drug reaction? So if they have, after having that episode, if they have had recurrent oral ulceration or ulceration in other mucosa, that's a -1. And then in clinical examination, typically patients who have recovered from SJS will have this patchy pigmentation. So there will be lightly pigmented areas, and usually patients in our country are a little pigmented. So they will have these lightly pigmented patchy areas on their skin, and that's where the new skin has grown back. They will have disfigured finger or toenails, and they will also have mucocutaneous abnormalities in the mouth. Okay, let me just take the liberty of fixing this so that I don't embarrass myself in future presentations. Thank you. They will also have dystichiatic eyelashes. They will have usually a symmetrical presentation. Symmetrical presentation means the degree of the symmetry will not be equal, but patients will have problems in both eyes. Okay, it will not be that one eye is completely dermalized and the other eye is wet. It rarely happens in SJS that way. They'll have dystichiatic lashes. They'll have symmetrical presentation, and if they have bulbar cicatrization without tarsal changes, that's actually also a -1. Sorry. All right. So if they have bulbar cicatrizing changes in without tarsal changes, so patients have a lot of cicatrization on the bulbar conjunctiva, but do not have cicatrization on the tarsal conjunctiva, that's also a -1. Grossly asymmetrical presentation, progressive symblepharon or dryness, recurrent membranous conjunctivitis. The patient has, or you have somebody has documented, or the patient tells you that they have recurrent membranous conjunctivitis. And also the history that we talked about of no sloughing off of skin or rupturing of bullae, and or history of recurrent mouth ulcers or node. So if you take all of this together, and if you get a score of more than 10, then you're very likely dealing with a case of SJS at 10. If you get a score of between 6 to 10, then it's very likely also that it is SJS. But if you get a score of less than 6, which is 1 to 5 or 0 to 5, it's very unlikely that it's SJS. I'm just telling you this, is not totally related to my talk, but I'm telling you this because once we start talking about the natural history of SJS, but we have not made the diagnosis correctly, then all of this is useless. And you will realize this. I'm sure there are a bunch of presentations tomorrow where people will be asking you the same question. I had this patient presented like this. Was this SJS? Was this OCP? Was this something else? And this is very common because we are seeing the end-stage sequelae, very difficult to then make a retrospective diagnosis. Okay? So the reason that we went and analyzed this data was because we wanted to find out if there are any differences in the chronic ocular morbidity of SJS in adults versus children, and what is the impact of the recent therapeutic advances. You also have to realize that mucous membrane grafts as a recommended treatment for MMG or something that is routinely done is very recent, like 10 years, not more than that. So we have an opportunity to understand, okay, we've been doing this for the last 10 years, how much has it really changed the life of patients? And also compare the ocular morbidity and the outcomes of various treatment strategies in adult versus children. Is it similar? Do adults behave just like children, or is it different? And this was a retrospective chart review of all the patients who were presenting between 1990 and 2015. So this is a time period of 25 years. What the advantage of doing this was, we got a large number of patients who were before this era of MMG and K-Pro and everything else, where we could study the natural history of the disease. It's very important to know the natural history of any disease for you to understand what impact you're making. Now, there are very few diseases that we actually understand the natural history of, because in today's time, there's nothing that you cannot treat. You will always do something. So, we understand the natural history of tuberculosis very well, or syphilis very well, because for a long period of time, in the history of annals of medicine, we documented what was happening to the patient when we did not have any treatment. There was no streptomycin, there was no penicillin. So we know what happens if we don't treat them, and we know what difference penicillin or streptomycin makes. But in today's day and age, you will always be treating the patient with something. And it's very important to know what happens if you don't know that. So this gives us an opportunity, because there's a time period where we can collect the data from patients where nothing definitive was done. Now, overall, the data that I'm going to present to you includes 568 eyes of 284 children who had SJS when they were young and presented as children. We have excluded the data of those who had SJS when they were children but presented as adults. Okay? And I'm going to compare that with the data of patients who had SJS in adulthood and presented as adults. So the pediatric data, we have published this in the American Journal of Ophthalmology. It took us several years to collect the data, analyze it, and if you haven't had a chance to read this paper, please do so. And I'm going to take you through what is the algorithm that we follow, and it's also described in this paper. And we have used the same for the analysis in adults. Okay? So typically, and we were discussing this yesterday during SJS Live, a lot of you were not there, so I'll just reiterate, is that there are patients who fall into the category of no keratopathy. No keratopathy means that they might have, lid margin keratinization, etc., but they do not actually have any keratopathy. When you do a fluorescein stain, nothing shows up in the cornea. This is very different from those who have dry eye related keratopathy. So you see a diffuse fluorescent staining on the corneal surface, not patchy. But when you see patchy staining, which I call differential staining, like you see in this patient, that you have fluorescent staining in this area and you have fluorescent staining in inferiorly, which also corresponds exactly to the areas that there is lid margin keratinization. This is lid-related keratopathy. Everybody who has fluorescent staining on the cornea does not have lid-related keratopathy. Mostly patients have dry eye-related keratopathy. If the patient has lid-related keratopathy, they will have differential staining. You will see staining in the area that there is lid margin keratinization or dystichiatic lashes. This is where MMG is primarily indicated. This is where it works, and this is where it makes a difference to the patient. And how much of a difference it makes, that is what I'll present to you. There's also end-stage keratopathy, which is the cornea is already dermalized or conjunctivalized or scarred, and there's nothing much you can do about it now by doing an MMG or giving them a PROSE lens. These are the patients who would need a keratoprosthesis. So what I'm trying to tell you here is that there is a group of patients with SJS who do not have keratopathy. Please always stain your patients to see if they have keratopathy or not. And if they do not have keratopathy, please do not prophylactically, unnecessarily do mucous membrane grafts in these patients. Nothing changes for them. And if you are starting out, if you don't do your graft properly, you can give them a host of problems, irrespective of whether they have keratinization or not. But do follow them up closely, and I'll tell you which patients to follow up particularly, because they might develop keratopathy subsequently. Then you have non-lid-related keratopathy. There's a diffuse fluorescent staining on the surface of the cornea. There is no differential patchy staining. There is no staining that corresponds to the area of the keratinization. They may also have lid margin keratinization. And then you have this. And I would again like to highlight, you see keratinization, and in the exact same area you see fluorescent staining. Okay? It may be not so discrete like this, but if you typically see the fluorescent staining concentrated in the superior half and inferior half of the cornea, they may still have diffuse staining in the center, but these are the patients that would typically benefit from MMG. And then you have end stage. This is where there's no point in doing an MMG. Very rarely will you have a case like this where the cornea is damaged or there's LSCD, but the eye is also wet, where you're planning to do an alloslet, etc., where you might want to do an MMG before you do that, but very, very rare scenarios. Okay? Now, what is the outcome measure that we chose for our analysis? We chose best corrected, and in most cases, this is contact lens corrected, scleral lens corrected, visual acuity. The reason that we chose visual acuity is that it's what matters to the patient. So in the same way as the common man does not care about what our GDP growth rate is, in the same way the patient does not care about how much fluorescent staining he has, or how much keratinization he has, or how much his fornical depth is. What the patient cares about is whether he can see and whether he can see comfortably. And that is most important. Interestingly, I'll point out the difference in the two groups. In the demographics of SJS is very different in children and adults in many ways. Okay? First of all, if you look just at the sex or gender distribution, you will easily see that females are much more common in the adult group than in the children group. I don't know why this is. I don't know if there is an actual sex-based predisposition, but this is what our data shows. Also, the other thing here is that if you look at the incidence or the prevalence or association of exanthematous fever, this is much more in children than in adults. In adults, it's not as common. Mostly patients have a history of drug intake. The only confounding factor in this data set is that we also have a significant number, which is about 16% in the children's group and which is about 22% in the adults group, where we don't know whether to attribute it to the drug or any other cause. So that is a confounder here. But otherwise, because this percentage is similar in both groups, you can easily see that the association with the exanthematous fever as an attributable cause for the SJS is much more commoner in children than is in adults. Also, the delay in presentation with the chronic sequelae to the ophthalmologist, there are more children who present very late. The adults present comparatively early. This could be related to referral patterns or bias, or maybe just amongst the two groups, and this is what is really worrying in our country, and I think that we need to work on this, and maybe I was just wondering yesterday, and I've thought of this before, that probably the ROP model that we have it needs to be adapted for SJS. You know, we need to reach out to the ICUs, the burn wards, or even the general wards where these patients are going and getting treatment. And we need to, form an ROP-like program where you regularly go and check if they have an SJS patient and give them treatment unsolicited and explain to them why this is important. And now that we have so much data to show why this is important. So the point I was trying to make, is that the disturbing feature here is that 99% of both children and adults did not receive an amniotic membrane grafting in the acute phase, 99%. Also, what we found is that there were slightly greater, higher proportion of children who had poorer vision at presentation or who were blind at presentation. And also a slightly higher proportion of adults who had more severe dry eye. Now, again, over here, the dry eye assessment has not been done in a lot of patients, so 14% of children and 24% of adults. So we don't know that if that assessment was actually done, if these numbers would change. But because it's similar in two groups, if we just look at the data, you will see that dryness seems to be more common in adults, significantly more common in adults than in children. But 60% of eyes of both adults and children had low vision or blindness at the time that they presented to us. Now, what is the natural history of no keratopathy group? So you all have, we have these patients. This is almost, you can see the number here, about 300 and odd patients who have who did not have keratopathy to begin with, and you will see that they, over a period, this is a follow-up of 10 years, over the period of 10 years, they mostly remain stable, particularly adults remain stable, but amongst children, particularly very young children, so if you look at the line at the bottom, children less than or equal to 8 years of age, some of these you need to keep under follow because even if they do not have lid-related keratopathy, if they have no keratopathy in the beginning, they do tend to develop, very small percentage, but they do tend to develop lid margin keratinization and over time, and because of the development of lid margin keratinization, they develop keratopathy, very small percentage. So, like I said, who are the patients with no keratopathy that you need to keep a close observation on? These are children, very young children, who may develop lid margin keratinization and subsequently keratopathy in the future. So this is an example of a child. He has significant lid-induced keratopathy in the other eye, but in this eye is wet. Okay, so I've been following him up for the last 5 years, and you can see the changes in the tarsus. So he had. This is immediately about 2 or 3 months after he recovered from toxic epidermal necrolysis. So you can see the granulation tissue here, there's scarring in the tarsus, and now 5 years later, this has kind of settled down, the tarsus is flat, there are no granulomas anymore, but his cornea is still pristinely clear, no staining whatsoever, his eyes are absolutely wet. So I'm still following up and keep following up this patient. He's developing lid keratinization, but no keratopathy yet. So I'm not going to jump to doing an MMG in this patient. This is another interesting case, an adult with significant keratinization. You can see clumps of keratin. I've been following this patient up for many years now, and he's also not developed any keratopathy. And the funny reason in this patient is that his eyes are wet, and he also has punctal fibrosis. Okay, so he has like a natural punctal cautery. He has actually epiphora. So that's his main complaint, is that he has watering of eyes. So I told him, that's much better than the alternative. So you just have to bear with it. So what is the natural history of non-lid related keratopathy? Patients who essentially have complaints, symptoms because of dryness and dryness related issues. So if you look at this curve, it shows that over a long period of time, the keratopathy worsens, corneas get vascularized, they develop healing problems, scars, etc. And then patients lose best corrected vision, and they can go from being very close to 20/20 to less than 2200 on an average. There are many patients who will go blind, there are many patients who will not lose as much, but overall, they'll go below 2200. And this downward trend is the significant deterioration is much worse in adults than in children. And I think the reason for that is that in children, they have greater reserve to tolerate this insult than adults. And we were discussing this yesterday also, that the stem cells, etc., may have a different limit to tolerate this chronic insult. Whereas in lid-related keratopathy, this drop is more significant. and again, much worse in adults than in children. So adults who develop SJS tend to do much worse if they have lid-related keratopathy than children. Again, I think that the ability for children to tolerate is maybe greater. In end-stage keratopathy, nothing much changes, except that some adults develop cataract and their vision drops. So, how do the therapeutic modalities change this natural history? Okay, so we're basically going to focus on mucous membrane grafting and scleral contact lenses. Now, the data that we have is on PROSE lenses because that's consistently what we have used for the last 10 years. But I think that if you were, instead of PROSE lenses, you were using some other form of scleral contact lenses, they would show a similar efficacy. In non-lid-related keratopathy, you can see initially it's very similar in adults and children. So there's an initial improvement. They don't have very poor vision to begin with. And this is stable over a period of time. Only you see a little bit of a dip in children as compared to adults. And this happens because the compliance rate in children, particularly in very young children, is a little bit lower. So we found that there was about a 17% non-compliance rate with PROSE in children, particularly younger children, as compared to only 5% in adults. So if you compare the effect of PROSE on the natural history of non-lid-related keratopathy, you can see very clearly that they begin at the same point, but here it's stable and here it's going down. So this natural history is getting significantly altered by the intervention of giving them scleral lenses. Now, all of these patients in both groups are receiving lubricants, they're receiving punctal cautery, they're receiving entropion, ectropion surgery, electrolysis for trichiatic lashes if they have, etc. That's all in the natural history group. Now, similarly, PROSE also has a beneficial effect in those who have lid-related keratopathy. Again, here there is a slightly higher non-compliance rate in children, and therefore they don't do as well. There is an initial improvement, but then there's a stabilization. But adults usually keep doing better, and you see a little bit of deterioration in children over time. This also has to do with non-compliance. But overall, it does significantly change the natural history. So something was going down, now it's going up. So that's very clear. MMG in lid-related keratopathy has a significant benefit in children. It makes things much better in children. So if you can just see this blue line, you'll see that even the vision significantly improves. Now, you don't really expect the vision to improve much with mucous membrane grafting, but it does, and I'll show you a couple of examples. But adults really don't do as well as children. So overall, the average, it remains flat. It doesn't go down as the natural history, but it's not as dramatic as in children. So I'll show you one example for the lack of time. This is a child, I think he's 13 years old. This is at the time of presentation. So it's very advanced keratopathy in both eyes, and you can see that there's exuberant keratinization, both upper lid and lower lid, and he has multiple distichiatic lashes, etc. But once this was addressed with the mucous membrane grafting, look at the improvement in the clarity of the cornea. Okay, now if you fit this child with a scleral lens, he'll see close to 20/30, 20/40 from this. And you see this in children happening. You don't really see this kind of a dramatic effect in adults. Instead, adults sometimes they keep having other problems. Like this young man, he had a very severe ulceration, which was treated with TABCL, and then it scarred, and now with PROSE lenses, he has a vision of 20/100 in this eye. What is also important is that when patients with chronic SJS develop infections or ulcers, we have a very low threshold for glue application, tissue adhesive application. Don't just keep treating them with antibiotics or lubricants or etc. Have a lower threshold for a tissue. It works really well. Even in patients with fungal infections with SJS, the response to treatment is much better with the tissue adhesive and BCL application. Maybe the BCL also helps, but it makes a dramatic difference. Just giving them drops, particularly very frequent drops, actually sometimes can make things worse, and the patients perforate very easily. This is another adult. She's, I think, around 55 years of age. She had MMG, very nicely done. But you know, she developed an epithelial defect. Then again, we had to treat her. Now she's okay with the scar. She has a cataract. We'll do the cataract surgery. So if you look at the effect of mucous membrane grafting in lid-related keratopathy and compare it with the natural history, again, significant difference, but a much, much more dramatic response in children as compared to adults. When you combine this, now this is where it gets interesting. So you have seen that there's always a little bit of difference between how adults respond and children respond. But if you look at when you combine, and Jim made this point about having this synergistic supplemental effect, complementary effect that they have, it's almost identical. And this is the group where you get best results. And if you look at MMG plus PROSE and compare it with the natural history, this is a dramatic difference. This line is going down, this line is going up. And you have patients almost recovering 20/20 vision here. Whereas here you have patients going down to 2200. Very dramatic difference. And I'll break this up for you in patients with lid-related keratopathy for children. So the three interventions, MMG alone, PROSE alone, and PROSE with MMG, you can clearly see from this breakup that in children, MMG plus PROSE is a clear winner. Number 2 is MMG. So in those patients that you will not be able to fit with a PROSE lens, mucous membrane grafting is absolutely mandatory in children with lid-related keratopathy. And in adults, again, PROSE with MMG is still king, but PROSE itself does much better than MMG alone. So PROSE alone is much better than MMG alone. And this is very different. So in children, MMG is better as a single modality. In adults, PROSE is better as a single modality. Just to give you an example, this young man, again, I'm using this photograph with permission, presented, I think, to me in 2013. We did mucous membrane, very severe dry eye. I mean, he has zero Schirmer's essentially. And we did a mucous membrane graft, very nicely done. He did well for a while, but then he started developing, he developed actually an ulcer in the right eye, non-healing defect, which resolved with a scar. And he was not very compliant with PROSE lenses at that time. But for the next 3 years, he's been using PROSE lenses, and this is what his corneas look like now. Okay? Look at the cornea in the right eye before he used PROSE lenses on a continuous basis, and this is what his looks like now. And he has excellent vision in both eyes with PROSE lenses, and you know he's very comfortable, opens his eyes. So if you looked at him, you wouldn't realize that he had SJS. Now I'm not going to go through the interventions, describe the interventions and their effects in end-stage keratopathy. It's a much more complicated area. We talked about it a little bit yesterday. We have published the outcomes of LVP keratoprosthesis, MOKP, and we have a data set on alloslet also, which we are looking to publish, which will give you an idea of how these interventions work. These, as you can see, the number of interventions that we have done are, you hardly can get patients who are eligible for getting these surgeries done. But when you do them right, they do benefit. So there is definitely a role, but this is a much more complex area. What I want you to focus on is just the group with the lid-related keratopathy and the non-lid-related keratopathy, which is the dry eye. So to conclude, what can we take from this data? I think it gives us invaluable morbidity and prognostic data. It makes things easy for us to explain to patients when we treat them that I'm doing your MMG, but what difference is it likely to make? So you can show them this curve that, if you don't do this, this is likely what is going to happen to you in the next 10 years. And this is how this modality is going to change things for you. We also found that females were more common amongst adults. We found that exanthomatous fever was more common in children. Delay in presentation was longer in children. Dryness was more common or more severe in adults. But the similarities were that by the time they presented to us, 60% in both groups had very poor vision, and 99% had not received an amniotic membrane graft in the acute phase. So this also gives you, I think, very invaluable data of what is the natural history of SJS if AMG is not done in the acute phase. If you don't do AMG in the acute phase, 60% of the patients, or at least 60% of the eyes of the patients, will land up with low vision or blindness, which would then become very difficult to treat. But we also found that the natural history in children and adults is very different. I think, like we said, that acute SJS and chronic SJS are two different diseases. In the same way, I think that SJS in children and SJS in adults are completely two different diseases that need a different approach. Young children with no keratopathy need close observation. Those with non-lid related keratopathy, in both that group and the lid related keratopathy group, the adults deteriorate faster than children. So you need to keep that in mind. And the possible explanation, like I said, for this is probably because of the ability of children, because they have greater reserve, the epithelium or the limbus, to tolerate these problems for a longer time before they develop severe complications. And in response to therapy, particularly in lid-related keratopathy, we found that the combination of MMG and PROSE is the ideal treatment for these patients. And let me re-emphasize this again, a combination of MMG and PROSE. So please, when you counsel your patients, tell them you will need both. It is not an option that you either take PROSE or you take MMG. Most of these patients will do very, very well with the combination of both. So if you counsel them on day one, they're more likely to get both and they're more likely to be compliant. If you do MMG and they still have persistent symptoms and then you ask them to buy a lens which costs 70,000 rupees, that's, for them, it's a loss of faith. But if you tell them on day one, I'm going to make things much better for you, what you're suffering from right now in terms of your vision and in terms of your symptom, I'm going to make you 70%, 80% better, but this is my plan and this is what works best for you. And I think if you counsel them right at the beginning, they do get both, they do very well. If you have a patient who needs a PROSE, who can't afford it, send that patient to us. We will give them a PROSE lens or a scleral lens at a discount, which you can determine. If you feel that this patient deserves a 50% discount, just send me a text, we'll give that patient a 50% discount. If you think that this patient needs a PROSE lens for free, we'll give them that PROSE lens for free. But please send your patients to us so that we can help them with PROSE lenses, they need them. And not being able to pay should not come in the way of treating these patients. Just before I finish, I just want to thank a lot of people who have worked on we've been collecting this data for the last 6 years, and I just want to thank all the research fellows who have worked with me on this project. Thank you.
Right. So thank you, Sayan, for that excellent talk on pediatric SJS. Yep.
So that's a fantastic achievement, and I credit you. The only, I have to say something negative, Sayan, I'm sorry. The only comment I have that I would ask you to rephrase is, I don't think that you can determine the incidence of severe disease in your sample because it's a biased sample. The patients are sent to you, obviously, because they have symptoms. You're not sampling the general population of SJS patients. So we don't, I would propose that, I cited this 1/3 with moderate to severe visual loss. That's a complete guess from retrospective studies, and yours is also a retrospective study. I wish we knew the true incidence of visual loss in SJS, whether treated with amnion or not, but we don't.
All right. So we had some questions from the
Yes.
attendees, and you covered most of the issues that they had raised. Again, there is a question related to what is the incidence of pediatric SJS worldwide. I don't think we have an answer to that.
We don't have an answer to, the incidence is very difficult to calculate.
Right.
Particularly in rare diseases. The classic way that epidemiologists like Jim would calculate incidence is that you take a cohort of patients who don't have SJS, like all of us in this room, and then follow us up for the next 10 years and see how many of us developed SJS, and then that would be based. But the problem is, if it is very rare, we know from whatever little incidence data there is that it's like the incidence ranges from like 0.5 to 6 cases per million. Now, for you to find that incidence, if it's close to that, I'm sure that it's higher in the Indian population. then imagine the sample size that you would require to follow. It's very, very difficult. So what you need is registry data. If you have registry data, then that's another way of getting that incidence. It's not true incidence, but it's close to what.
If you have a reportable disease, that's the other way that it's
Yep.
done. So if there's mandatory reporting of a disease, then you can get accurate incidence
So
rates.
there's something where again the ROP model could come in handy because they have now very good data on
We are
ROP,
trying to
so-
calculate something called hospital-based incidence, which is of all the new patients that have come to our hospital over the last so many years, how many of them came immediately after having SJS.
The other-
And from that data, I can tell you it's about 100, I think 100 per million.
The other way you can do it is if you have a single healthcare center in a region that really captures all of the healthcare in that region, like the Mayo Clinic used to do, you can the Olmsted County in Minnesota. You could say, well, in this county, since we provide essentially all of their medical care, you can determine incident rates that way, but it's very difficult.
Yeah, I think since you are from PGI and you people cater to a lot of SJS, acute SJS, you being a dermatologist, what do you think about the incidence of children versus adults? Because we clearly see the intervention in children can make a difference and vis-a-vis adults. So what do you feel, how's the incidence?
The exact incidence of SJS is not known, especially the Indian prevalence and Indian incidence is not known. But practice-wise, we see both adult SJS and pediatric SJS in the same frequency. But the associated comorbidities and the possible triggers for SJS and TN in children are different from that in adults. So the prevalence, the incidence is the same in children and adults.
So,
at
but-
least what we see. in
But when you
practice.
call children up to what age and you
12.
call adults from, so if you see the same number of children 12 and under as you do adults 13 to 90, then you actually have a much higher incidence in children. If you-
Yeah, probably.
Right?
Right. Yeah, but there are opportunities for like institutes like PGI, which capture a lot of data from around the northern states. So,
Also,
yes.
something that I forgot to mention is that even within the adults, the younger the adult, the better the response to treatment. The older the adult, so if you have somebody who gets SJS in their 60s, it's a completely different scenario and much more difficult to treat. And they go downhill much faster.
Do you think that's because of the aging effect on the
I think it's
stem
just
cell reserve? Or
just the body's response to insult.
I would be covering this in my presentation, but age is the most important prognostic factor in acute SJS.
I see.
The higher the age, the
for mortality?
mortality outcome is definitely worse.
Yeah.
All right. So any of you have any questions for Dr. Sayan Basu, who is going to leave after this session? So anything related to what he spoke about, MMG, PROSE, pediatric SJS in general, yes, please.
That was an excellent presentation, Sayan.
Thank you.
Huge data. Just had a few comments. I think it was quite a lot of data that you presented.
I know, I'm
So,
sorry to overwhelm you guys.
Yeah, so when you talk about MMG and dry eye, especially in the last example that you cited of improvement with the PROSE, probably it's important to differentiate the lid-related keratopathy with the dry eye-related keratopathy and not attribute the non-improvement to having occurred even despite having done a mucous membrane graft. Because here you
No,
have
there
two
is
different-
improvement. There is improvement in
Yes,
mucous
so,
membrane graft. Which group are you talking about?
The adult group. where
Adult,
you
there
said
is
that-
improvement, but not as dramatic as children.
Yes,
There is
where
improvement
the-
in both groups.
where the PROSE lenses seem to have done better than your pediatric group, at least in the case where you showed, it had more to do with the dryness that was responsible for the keratopathy in the eye and not the lid-related keratopathy. So you basically need to make a difference between whether it's the lid-related keratopathy that you're addressing with the mucous membrane grafting or whether it is the dryness, because a mucous membrane graft doesn't really do much to the dryness in the eye.
No,
So
it does not.
expecting that the eye.
does
But
not.
your
But-
paper has addressed that. The mucous
It
membrane
does
graft
not.
is specifically.
I understand your question.
Yeah.
So the thing is that dryness is there in both groups. So if you have the non-lid related keratopathy group and the lid related keratopathy group, both have dryness. Only one group has the keratopathy which is additional keratopathy which is attributable to the lid margin keratinization. So there are two issues to be dealt in those
True,
people.
that's exactly what I'm trying to say, that there are
So
two issues
when you give a
and we
PROSE,
shouldn't basically misunderstand that the mucous membrane grafting is going to address both. So right in the beginning, if you have both the issues, we need to be clear that this is a patient who would require both mucous membrane grafting and PROSE, and not attribute the final outcome to, one over the other.
No. The comparison here is with the natural history. The comparison is not between the groups. This is the first important thing to understand. So the point is that all of these interventions change the natural history. The extent of the change is different. So in children, what happens is that the corneas do get much clearer just with the MMG, and their vision also, because of that, improves. In adults, like you said, because they also have a component of dryness which is not addressed because of just by doing the MMG, they do become stable over time, but their vision does not necessarily dramatically improve. But a flat curve in SJS is much better than a curve that is going down. So both MMG and PROSE change the natural history. The extent of the impact is different in adults and children. The extent is different, but the impact is similar in both groups.
Oh, yeah. My question is, could you give us some guidelines, because you've written like dryness grade 1 and 2 in the earlier stages versus severe in end stage. So for us to clinically determine, is there an overlap of some patients?
There is always overlap. So end stage basically is not governed entirely by the dryness. End stage basically means where the cornea is not salvageable. So just by doing an MMG or giving the PROSE lens, the vision is not going to improve. That's end stage. So that helps us because, we do tend to do mucous membrane grafts in patients who have very poor vision. You don't want to do a K-Pro. You say, okay, let's do an MMG and see how much the vision improves. You can do it, but it's not going to impact because it's already damaged quite a lot. So if you include that into the data, then it's going to confound the effect of the mucous membrane graft or the PROSE lenses, because there you don't expect. So we are looking in the LRK and in the NLRK group, we are looking at corneas that can be salvaged. And what is the impact of MMG and PROSE in those eyes?
Right, I have a question related to the scoring system that you showed, which I think is going to be very, very useful. Just one point is that you gave a -1 for patients who had progressive symblepharon or dryness.
Yes.
So, in your thought process, do you think that patients with SJS should not have progressive symblepharon or dryness over a period of time?
Progressive symblepharon, no.
Okay.
And especially if the patients, like somebody who comes, I have had patients who've had SJS, a decade ago, and they'll say, I have noticed that this symblepharon is getting worse. Or if you can document it. I mean, most patients, if it's a superior symblepharon, patients won't notice. There's no way they can tell. But sometimes, you have patients who are very perceptive, and they do notice those things and say, things are getting worse. This was not there before. And that should, what I'm saying is it should raise a red flag.
Okay.
So entertain the possibility that this might be something
progressive
else.
dryness?
So the important thing here is that, because in earlier workshops we had this discussion over and over again about the importance of lid margin keratinization, lid margin keratinization, lid margin keratinization. Now that everybody started looking at the lid margin, we know that, lid margin keratinization is not specific to SJS. When we were looking only at SJS and lid margin keratinization, it looked like a clear association. But now we know for sure that lid margin keratinization can occur in all cicatrizing conjunctivitis and even severe non-cicatrizing dry eye. The point is, each of these signs and points in history in isolation are not diagnostic of SJS. You have to take the whole thing into account. That's why you have the scoring system of, like, if somebody scores really low on those points in history,
very unlikely that they would.
You have to think that maybe this is not SJS. I need to work this patient up, do a conj biopsy, etc. But if the patient is scoring, above 10, it's very likely that it's SJS. They might get enough points just from the history for you not to even look at the eye and make a diagnosis of SJS.
Yes, one more question.
Dryness does progress over time in SJS. I understand about symblepharon, it should not be progressive in nature, but what about dryness?
Not really. Patients, so after they've recovered from the acute phase of SJS, the only thing that progresses in these patients is the keratopathy and the visual loss. But the dryness, the symblepharon, these things do not get worse. Whatever they are left with after having recovered from acute SJS is what they have for the rest of their lives. But the sequelae mostly is the impact on the cornea.
But it can, sinus age. I mean, people, right? It's not like.
But not a dramatic change. People don't go from a Shermer's of 10 to a Shermer's of 0.
I agree with that. But so the patient's perception may be that it's getting worse, though.
Yeah.
Patients will come in
Yeah.
and tell you, gee, I was okay, and now I'm
Yes.
much drier. That's why I say always look at those puncta, because they open up again.
One more thing that I wanted to say yesterday, but I forgot, was looking for dryness in patients with ocular surface disease can be tricky. I know that nowadays, Shermer's doesn't have a good reputation, and most of the, like the dry eye workshop will not even take a Shermer's value as a diagnosis of SJS, as a diagnosis of dry eyes. But a very useful test. The only thing that you need to keep in mind is sometimes when you're doing Shermer's, you're measuring the paracaine that you've just put, or sometimes you're just measuring the lubricant drop that the patient has just applied before walking into your examination room. A workaround, easy workaround this is do your Shermer's and then repeat it. Your second reading is always more reliable. So you will sometimes see the first reading will give you a value of 10 or 15, but the second reading will be 0. So put paracaine, do Shermer's, repeat Shermer's.
Rashmi has a question. Yeah.
Who would not have had any lid margin signs. They did not have keratopathy, of course.
Yes, of
and
course you
also
have.
no lid run.
Yes, you can
So
have.
does that mean that lid margin keratinization, it's not specific, but what I'm asking is it essential to chronic SJS? Having lid margin changes, is it essential?
And you have like patients without any lid margin change.
You
can.
have the 10 plus score.
You can have patients who do not have lid margin keratinization at all after SJS, okay? But these are patients that will not come to an ophthalmologist. I've seen, very rare, that they don't have any lid changes, they don't have dry eye. So they'll have either of these two. They'll either have dry eye or lid keratinization.
If they have the bulbar signs, that is they have dry eye, they have the other signs, but not lid margin related signs. And then how do we get confused then? Because then we would say,
No, don't get confused.
Is it something
Don't
else?
get
Is it not
So if you
SJS?
have a patient who has cicatrizing conjunctivitis with dry eye, but does not have lid changes,
Yes.
lid margin changes, does not have keratinization or does not have distichiasis, is not SJS. Take their history again. I will take every patient's history again. So I'll tell you what happened to you. They'll say, I had SJS. I said, no, tell me what happened when you thought you had SJS. Or they'll say, I had a drug reaction. But the doctor told me I had chickenpox. I said, no, I don't want to hear that. Tell me what happened when you had that episode. What were the sequence of events?
And I believe
And
Dr.
every SJS
Thodos is
patient
going to talk
will
about
give
that.
you the same history. I had fever, I had this, then I took some medication, I had rashes all over my body, I went to the doctor said, oh, this is nothing, this is chickenpox. And then I took the tablet again, and next morning my whole body was covered with boils, my eyes were red, I couldn't open them, my mouth was there. It's the
But
same.
this-
Everybody will
this-
give you
this
the
may
My
be
nails
for a-
came off, my skin came off, it regrew again.
This may be for a patient who is coming in the chronic stage to you. What about a patient who's coming in the subacute stage? He can walk up to you. At that time, the patient may not have lid margin signs, is what I'm asking. Is that a possibility? And then
They will have
therefore
some
you
lid
have-
margin signs. It's not as if
Have to.
somebody will have a pristine, healthy lid margin and later develop keratinization. They will show early, like Jim showed in that photograph, very severe myomitis. And later on, those myomin glands will close off. Then they will develop a posterior migration of the mucocutaneous junction. Then they will develop distichiasis over time. That can happen.
Make a distinction when you say that that patient doesn't have SJS. I mean, it depends on how closely you look at the lid margin. I would agree that the patient with the pristine, healthy lid margin who thinks they had SJS probably doesn't. If they also have dry eye and other changes. But some of the changes are not quite so dramatic. And patients after amnion sometimes will have dryness. You know they had SJS because you treated them acutely. They had a positive skin biopsy. And they can have, again, there's levels, right?
Somewhere in between.
Yeah, somewhere in between. So it may not be that severe lid margin disease, but if you look, you'll see abnormalities. So I'm less absolute. But
So let me rephrase that. My bad. So what I'm trying to say is, like I said before, any of these points in the history of the patient or the clinical examination of the patient by themselves don't tell us what the patient is. Take an overall view, and if you can build a narrative, all the pieces of the jigsaw fit together, and then it's SJS. And if some of the pieces are missing or some of the pieces are not fitting together, then at least entertain the possibility that it might be something else. Do a conj biopsy, do an autoimmune workup in those patients. That's all I'm saying.
Right. Thank you so much.
Thank you.
And
So again, my apologies that I'm not going to be able to hang around, and I wish all of you a fantastic next 2 days, and I'm sure that you'll go back with a lot of new information and a lot of new enthusiasm and vigor for treating SJS patients. Thank you all of you for being here, and have a wonderful OSW. Thank you.
So today I'd like to talk about the predisposition and pathogenesis of Stevens-Johnson syndrome with severe ocular complication. So today's topics consist of the 3 subjects. First subject is the causative drug and HLA for Stevens-Johnson syndrome with severe ocular complication. So Stevens-Johnson syndrome, SJS, is an acute inflammatory vesicular blast reaction of the skin and mucosa, such as ocular surface and oral cavity and genitals. In the patient with extensive skin detachment and for prognosis, the condition is called toxic epidermal necrolysis 10. So in the acute stage, patient manifests vesicular blast lesion of skin and mucosa, severe conjunctivitis, not good, severe conjunctivitis with pseudomembrane and ocular surface epithelial defect. In the chronic stage, despite feeling of the skin lesion, severe ocular complication persists, such as severe dry eye, conjunctive invasion into the cornea, gineblepharon, trichiasis, and sometimes result in the visual disturbance. SJS is mucosal lesion and consists of SJS and a part of 10. So, okay, so, can I exchange this? So, and I cannot so the moreover, not all but some of SJS with mucosal lesion complicate severe ocular lesion, such as severe conjunctivitis with pseudomembrane and ocular surface epithelial defect. So, can I use a pointer? So, dermatologist, okay. Dermatologist sees a SJS-10 patient only in the acute stage. On the other hand, ophthalmologist encountered SJS-10 patient not only in the acute stage, but also in the chronic stage. So our diagnosis of SJS-10 was based on a confirmed history of acute onset high fever, serious mucocutaneous illness with skin eruption, and the involvement of at least 2 mucosal sites, including ocular surface. Thus, ophthalmic lesions appear in not all, but some of SJS-10 patients who diagnosed by dermatologists like this. SJS-10 are rare, but often associated with inciting drug. Some causative drugs were reported. For example, allopurinol, which is uric acid lowering drugs, and carbamazepine, which is an anticonvulsant. So interestingly, Korean collaborator reported that allopurinol-induced Stevens-Johnson syndrome might not have severe ocular complication. This is the ocular surface of the allopurinol-induced SJS patient. So mild conjunctivitis, mild conjunctival hyphema with lid margin inflammation, accompanied by the clear corneal surface. For SJS-10 patient with severe ocular complication, so we reported the main causative drug might be cold medicine, including NSAID or acetaminophen. So this is a causative drug of SJS patient with severe ocular complication in our university. So 77.7% causative drug is a cold medicine. And among the total cold medicine, so 56% is cold medicine from hospital, and 16% is commercial cold medicine, and 5.3% is from the both. So detailed non-group was 42% in total cold medicine related SJS-10 group. In the detailed non-group, 39% were accompanied with antibiotics, while 61% without antibiotics, suggesting that it is possible to exclude the effect of the antibiotics. So this is a component of the cold medicine which are detailed known. So acetaminophen is most frequent cold medicine for the causative drug for SJS-10 with severe ocular complication. In Brazil, cold medicine is the main causative drug of SJS with severe ocular complication. Our Brazilian collaborators also reported. So the 53% is cold medicine. Okay. So the Korean collaborator also reported that cold medicine might be associated with severe chronic ocular complication. And Thailand collaborator also reported that cold medicine is main causative drug for SJS-10 with severe chronic ocular complication. So about 69% have a history of taking cold medicine before the onset of SJS-10. And the main cold medicine is acetaminophen. Thus, there is a difference of causative drugs between the patient with severe ocular complication and without severe ocular complication. So, moreover, some association with HLA and the drug were also reported. For example, the allopurinol-induced SJS-10 was reported to be associated to HLA-B5801 in Han Chinese, Caucasian, and Japanese, and carbamazepine-induced SJS-10 was reported to be associated HLA-B1502 in Han Chinese, and HLA-3101 in Japanese and European. So we performed the HLA analysis of cold medicine-related SJS-10 with severe ocular complication. This is the result. In Japanese, HLA-0206 was strongly associated with cold medicine-related SJS-10 with severe ocular complication. Odds ratio is 5.6. And HLA-B4403 was also strongly associated, also significantly associated with them. So odds ratio is about 2. So compared to the Japanese cold medicine related SJS-10 without severe ocular complication, they significantly remain. This result shows that HLA-0206 and HLA-B4403 are significantly associated with the cold medicine-related SJS-10 with severe ocular complication, but not without severe complication. Thus, different phenotypes have a different genetic predisposition. So on the other hand, HLA-0206 and HLA-B4403 are not associated with cold medicine unrelated, other medicine-related SJS-10 with severe ocular complication. Thus, different causative drugs have a different genetic predisposition. So we also examine the association with the HLA-0206 and HLA-B4403 using other ethnic samples such as Korean, Indian, and Brazilian samples. So HLA-0206 is also associated cold medicine-related SJS-10 with severe ocular complication in Korean, but not Indian and Brazilian. Like this. So the HLA-B4403 is associated with cold medicine-related SJS-10 with severe ocular complication in Indian and Brazilian, but not Korean. So especially in Indian, so the HLA-B4403 is strongly associated. 60% of the patients have HLA-B4403, while only 11% of control have it. Odds ratio is 12. So in the Brazilian, when we focus on the Brazilian Caucasian, 40% of the patients have HLA-B4403, while 10% of control have it. Odds ratio is odds ratio about 6. So the cold medicine-related SJS-10 with severe ocular complication was associated with HLA-0206 in Japanese and Korean, and HLA-B4403 in Japanese, Indian, and Brazilian Caucasian. So there is an ethnic difference in HLA types, including SJS-associated HLA. So moreover, international collaborators have analyzed all HLA class 1 in addition of HLA-0206 and HLA-B4403 and found other associated HLA type with SJS-10 with severe ocular complication. So Brazilian collaborator found that HLA-6601 is significantly associated both Pardo and European cold medicine-related SJS-10 with severe ocular complication. Pardo means a mix of African and European. And HLA-C1203 is significantly associated with European SJS-10 with severe ocular complication. So Indian collaborator found that HLA-B4403 and HLA-C0701 haplotype is significantly associated with SJS-10 with severe ocular complication. So the 44 of the 8 SJS-10 patients with severe ocular complication harbored the HLA-B4403 and the HLA-C0701 haplotype, and like this, and while only 5 of the 50 controls, 10% have it. Odds ratio shows 11. And so so about 52% of the cold medicine-related SJS-10 with severe ocular complication also harbored HLA-B4403 and HLA-C0701 haplotype. So the ratio is about 10. So Thailand collaborator also found that HLA-B4403 and HLA-C0701 haplotype is significantly associated cold medicine-related SJS-10 with severe ocular complication, like this. So short summary is, the cold medicine-related SJS-10 with severe ocular complication was associated with HLA-0206 in Japanese and Korean, and HLA-B4403 in Japanese, Indian, Brazilian, Caucasian, and Thailand. So, intermission. So, no, that's half, okay. So the next subject is abnormal innate immunity and pathogenesis for SJS with severe ocular complication. This is the ocular surface of the SJS-10 with severe ocular complication in the chronic stage, and decolonization of MRSA, MRSE, they reduce ocular surface inflammation. So what does this finding show? So that we suspected that abnormal innate immunity in SJS. So innate immunity, which are early host defense against microbes, is primarily studied in immune cells such as macrophages. Macrophages phagocyte and recognize microbes and produce inflammatory cytokine and chemokine and result in the inflammation. However, so that it have recently become clear that mucosal innate immunity with the presence of commensal bacteria seems to be different from the conventional innate immunity. So the ocular surface is one of the mucosa contacting with commensal bacteria. We isolated commensal bacteria from conjunctiva sac from the healthy to healthy volunteer. So the Staphylococcus epidermidis was detected from the 45%, and the Propionibacterium acnes was detected from the 31%. So although the ocular surface contacting with commensal bacteria, the ocular surface does not respond to the commensal bacteria, nor does it induce the inflammation. So although the detection of microbes is the most important task of the innate immune system, exaggerated host defense reaction to the endogenous bacterial flora may initiate the perpetuated inflammatory mucosal response. So we speculated that the ocular surface harbored unique innate immune mechanism to regulate inflammation that can be induced by microbes. So moreover, SJS with severe ocular complication often have opportunistic infection of the mucosa of the ocular surface by bacteria, especially MRSA or MRSE. So this is the detection of the MRSA, MRSE in the conjunctiva sac of severe ocular surface disorders. Compare the other devastating ocular surface disorders such as OCP and chemical burns. The detection rate of MRSA, MRSE was higher on the ocular surface of Stevens-Johnson syndrome. So SJS patients in the chronic stage often have a severe ocular surface inflammation when MRSA or MRSE reside on their ocular surface. Although the inpatient without SJS also often carry the MRSA, MRSE on their ocular surface, they have discharge but no severe ocular surface inflammation. Decolonization of MRSA, MRSA reduce ocular surface inflammation. So the SJS patient often shows a hyperinflammatory reaction against the commensal bacteria. So I hypothesize that abnormal innate immunity may occur in human ocular surface inflammatory disorders, especially SJS. So balance between the mucosal immunity of the ocular surface and the pathogenicity of bacteria is important. When the host mucosal immunity is normal, commensal bacteria is symbiotics. However, so if the host mucosal immunity is abnormal, commensal bacteria can be pathogenic, like in SJS. So immune cell respond to bacteria. On the other hand, mucosa does not respond to the commensal bacteria. However, disrupt of mucosal immunity, such as SJS, ocular surface inflammation can be occurred. So short summary to the abnormal innate immunity may contribute to the pathogenesis of SJS. So to elucidate the pathogenesis, we performed the genetic analysis and found that some genes are associated with SJS-10 with severe ocular complication. So TLR3 SNP are strongly associated with Japanese cold medicine-related SJS-10 with severe ocular complication. TLR3 is one of the toll-like receptors which are very important in innate immunity. TLR3 recognizes viral double-strand RNA, and we also demonstrated that TLR3 positively regulates ocular surface inflammation and positively regulates the skin inflammation. Thus, the TLR3 positively regulates mucocutaneous inflammation, including the ocular surface. And EP3 SNPs are also strongly associated with Japanese cold medicine-related SJS-10 with severe ocular complication. EP3 is one of the prostaglandin E2 receptor like this, and cold medicine such as acetaminophen and NSAID suppress prostaglandin E2 production. So we also demonstrated that prostaglandin E2 acts at EP3 in epidermis and mucosal epithelium and negatively regulated mucocutaneous inflammation. So this is the mouse model, so the dermatitis model, ocular surface model, and asthma model. So we also examine the expression of EP3 on the ocular surface. So EP3 in conjunctival charesis and chemical burn, EP3 is strongly expressed in the conjunctival epithelial cells. However, so the EP3 strongly downregulated in conjunctival epithelium of SJS, so like this. So IKZF1 SNPs are strongly associated with cold medicine-related SJS-10 with severe ocular complication. So this is a genome-wide association study using 170 Japanese cold medicine-related SJS-10 with severe ocular complication and 691 controls. So HLA region shows the strongest associated, but we can find the IKZF1 gene also. So we analyzed the association with IKZF1 gene using the other ethnic samples such as Korean, Indian, and Brazilian. So Indian also shows a significantly associated. So the meta-analysis shows genome-wide significantly association between SJS cold medicine-related SJS-10 with severe ocular complication and IKZF1 gene. So the P value is very low. So to examine the function of IKZF1 gene, we made the IKZF1 transgenic mouse and found the IKZF1 transgenic mouse developed the dermatitis. And we also found that some IKZF1 transgenic mouse also developed peripheral conjunctivitis. So the histological analysis also shows that dermatitis in the IKZF1 transgenic. So there was mild sickness and epidermis and mild infiltration of the inflammatory cells in the low line. So we found also that in some IKZF1 transgenic mouse, there are inflammation in blepharoconjunctiva and tongue and paresthesia, as same as the patient of cold medicine-related SJS-10 with severe ocular complication in the acute stage. So summary 3, there is a many susceptibility gene for cold medicine-related SJS-10 with severe ocular complication. So last subject, my hypothesis about the mechanism for SJS-10 with severe ocular complication. So in Japanese, several SNPs are associated with cold medicine-related SJS-10 with severe ocular complication. So multiple susceptibility gene for SJS might constitute a network. For example, the EP3 suppress the TLR3 ligand polyic-induced cytokine, so like this. And IKZF1 IKZF1 was upregulated by TLR3 ligand poly-IC. So the other group also reported commensal bacteria regulated TLR3 dependent inflammation. So lack of balance between these genes can trigger mucocutaneous inflammation of SJS. So abnormal innate immunity might contribute. So the multiple susceptible gene for SJS might constitute a network. So when network balance is good, so homeostasis is maintained. However, so there is a multiple susceptibility gene polymorphism. So network balance become bad, so the SJS can be developed. So we also found the HLA-SNP interaction might contribute to the prediction for SJS. So the combination HLA and SNP shows a high odds ratio like this. So in future, we can predict for the onset of SJS, I hope. So, okay, thank you very much for your attention.
Right. Thank you, Dr. Waiter. Any questions for her about the innate immunity mechanisms in SJS or the genetic predispositions for SJS from any of the audience? Yes, Dr. Sangma.
Do you people use immunosuppression for the management in the acute stage?
Acute stage?
Yes.
No, and so the only pulse steroid and sometimes IVIG.
Okay.
No
and
immunosuppressant.
IV methyl prednisolone you use?
Yes, IVIG. So in Japan, so the insurance covered IVIG.
Okay.
And
IVIG, not IV methyl prednisolone.
yes, and subacute stage, so that we use sometimes immunosuppression. So cyclosporin.
Okay, thank you.
Okay, you showed a photograph, after decolonization of the ocular surface, the inflammation decreases. So by that you mean you use antibiotics, topical antibiotics? What do you mean by decolonization?
Yes, so we use usually the chloramphenicol. So the chloramphenicol is effective MRSA. And if the chloramphenicol is effective, we use the vancomycin. Okay. And so sometimes we use the Bacter, which effective for MRSA, systemic Bacter intake.
So just with the antibiotics, the surface changes like this, or is it also with additional use of steroids or something else?
That's the chronic stage.
Yes, you showed an eye which was very inflamed, and after decolonization, it looked very quiet.
Yes, so the reduce the colonization, so ocular surface inflammation, so reduce.
Only antibiotics? Or
yes, no steroids.
No steroids.
So the low concentration steroid eye drops.
Okay.
No immunosuppressant.
No immunosuppression. Right.
The you people have lot of MRSA on the ocular surface in SJS patients.
Yes.
And you believe that it adds to the inflammation, right? It contributes to the inflammation.
Yes. So
the data from LVP, do you remember Bhupesh recently published?
Yes.
We don't see that
much of
that much of MRSA in SJS.
Maybe in Japan so the doctor often use the antibiotics
resistance increases.
Yes,
we also use.
So the antibiotic resistance is totally mind.
Yeah, we probably use more than Japan,
Yes.
but yeah, that's all right. Someone else? Yes, some questions, comments?
Here, I have a question. So, do you do cultures like regular basis to the acute stage or to the acute stage?
Acute
to the
stage?
conjunctiva, like cultures. To know
Cultures in the acute stage, how do you know that they have MRSA?
So do you know, like
did you do culture from the surface in the acute stage? Like take a conjunctival swab and
Yes, so the cultures.
Cultures.
Every patient. So the
Every patient.
Every patient. And chronic stage also, so that we often the cultures the discharge.
Right. Any more questions? Any comments? Thank you, Dr.
Thank
Waiter.